wanted to talk a little bit about the NRG LU-005 study that was presented at ASTRO by Kristin Higgins, because it's going to help me change my practice of care. And they took that chemotherapy, radiotherapy backbone and tried to give concurrent and consolidative atezo. Atezo did nothing to increase the survival over the control arm of chemotherapy and radiotherapy. Atezo led to significant increase in the adverse events that led to death. This is not what we're supposed to be doing, but I like doing it anyways. And what you can see in the original Teresi study, the median survival was about 23 months. And both CONVERT and the CLGB study with Jeff Bogart increased it slightly. But with Adriatic and the addition of Durva to chemoradiotherapy really knocked it out of the park. It's also worth noting that in this study, LU-005, the control arm did really well. So overall, we are making progress in this disease. In this study, radiotherapy was not randomized, but the BID treatment versus once-a-day radiotherapy, it's hard to ignore that the BID is outperforming. And this is why this study is going to change my practice. And it's also important to note that in Adriatic, the same thing was identified. Furthermore, in Adriatic, they found that the use of BID correlated with PCI and also correlated with less than 14 days in starting Durva from the end of chemoradiotherapy. I realize this is probably some type of selection bias, but it leads me to believe to say that if we have patients who are doing well, it may be beneficial to give them the ability to have as much intensity in their therapy to beat their disease. This is what I've learned from this study, and each one of these points will probably be a separate video. But Durva is really altering the playing field in lung cancer when combined with radiotherapy in the consolidative setting. Concurrent immunotherapy and radiotherapy has some challenges, and I just think it's not ready for prime time yet. This study also has me now favoring BID treatment over once-a-day radiotherapy, and I think we need to discuss further the use of PCI. I would not like to see another large randomized study of BID versus QDA or the use of PCI. What I really think we need in this disease, which is something Kristin has told me in the past, is better biomarkers to guide therapy. It would be more beneficial if we had biomarkers to say which patients can tolerate BID versus QDA than anything else we could come up with in this disease. Thanks and have a good day.